if our, if crisis stabilizations, if we don't have the volume for it, or just something to be able to have on even our smaller islands like Lanai and Molokai. And of course, duplicating those efforts, not only for adults, but for children as well, is kind of the goal. So thank you.
Thank you, Belinda.
And then the last element in this mini proposal, again, they're just very selective in what they're asking for. It's really about the state council. And it has a question: how was the council involved in the development and review of the state plan and report? I honestly think the SAMHSA didn't even change this question. They were really meaning this particular mini proposal, narrate in the text box. So I started basically copying what we said last year, basically documenting the process. So you can enrich this later on after, after we go through all the processes. And then there's this question of really what SAMHSA I noted here is it's really asking this group, the DOH and this council, to think about the mechanism where we kind of look at community mental health, substance misuse prevention, SUD treatment, and recovery support services together. So I was trying to say, why are they asking this question? So they're really just motivating us to think about that, that interface. And then, in fact, there's a question: how has the council successfully integrated substance misuse prevention and SUD treatment and recovery or co-occurring disorder issues, concern, and activities into its work? And it's not asking you to explain anything of what you've done. It's just asking you yes or no. So in last year, I just assessed what I thought was the right answer. This year, I would like to throw it to the council and say, what's really your assessment? Yeah. And there's no right or wrong answer. It's just an assessment of where we are at. Yeah. And then let me see. I think that's one of the major questions that I thought I'd point out to you. Where I'm lost.
So
yeah.
No, thank you. I do have a couple comments, but I want to make sure you're able to go through first.
Yeah.
Carolyn.
So there's a question, and then has the council successfully? Okay. And then this other thing is really more of a technical question. They're really taking a look at our membership, our membership in Hawaii, and seeing whether we're meeting that, majority non-provider statistics, and whether we have all the 8 government agencies represented. Yeah. So as you know, we don't have housing. Okay, so that's it. And then at the end of the day, they'll ask us, how did we make the public aware? And then, as you noticed from last year, we also, in the final plan, we did submit the public comments. Yeah, you did have public comment already starting from August when your committee met. Yeah, you had that one lady visit us and gave her comments. Okay, so that's about how this federalish mini proposal is looking like, but hopefully that this at least gives you an inkling of where the DOH is going with funding, as well as priorities and directions. So thank you. And maybe Marian has something to say. I'm just saying DOH, and when it really is more the gathering of information at this time. Yeah, and maybe Gavin. And I think Kaylee Wheel said she'll come later if she has a meeting, and she might add some points too. Again, as far as directions, I do defer to our leaders. As far as the technicalities, of course, I have to take a look at that all the time against SAMHSA rules and against our rules. Thank you. I'm Pau.
Thanks, Carolyn. No, very thorough as usual. And you and Val, I want to just say extreme gratitude to you both for all your work on this. I know it's a lot of work, so thank you so much. And before I ask my questions, though, I want to make sure if Gavin or Marian has anything that they want to say, or Belinda.
Sure. Thanks to the chair, and also to Carolyn and Val. Recently, Dr. Matsu, Kaylee, and myself attended the NASHPT conference, which is a national conference of folks who oversee state behavioral health. And the entire conference was dedicated towards crisis and crisis intervention. There is some real concern, particularly on the mainland, about suicide and on suicide ideation and our response to it, not just for adults, but also kids. So the direction and message was kind of clear, since NASHPIT is also kind of a knockoff of SAMHSA, without all the government bureaucracy. So I think that we really have to take a good look at how we're spending money in crisis and whether or not we're doing enough. But I'm also going to add that it's a continuum. And if you grow the pipeline in one area, you've got to make sure that that pipeline is, you know, built out throughout the system. So always cautious about that.
Mm.
Thanks.
No, thank you. Marian, and can I ask, do you think the current proposal embodies enough for in terms of the of what's allocated for resources and money to meet that crisis? Yeah, I know 5% has to, but
Right. I definitely think that we need to take a good hard look at that. We're going through our budgeting process right now for state. So of course, you know, that's going to be a balancing act.
okay. Thanks. And then, thank you so much, Dr. Suji, really appreciate that. And then Gavin or Belinda, is there anything else that you wanted to add on?
Hi, everyone. I don't have anything to add on to that, but I just wanted to thank Carolyn and Val for their tremendous work getting this the mini proposal in. Thank you.
All right. Thank you so much. And Belinda, since I haven't heard from you, I'm going to assume you're okay. I had a couple comments, but I also want to make sure if there's anything from the council that anyone wants to bring up too. Yeah.
This is Leah.
Leah,
Sure.
thanks.
I have what is probably I know is a very remedial question. But this SAMHSA, this block grant, is this the majority or is it all of the federal funding for CAMD and MHD and the state council?
It's a good question. I know though, so this funding is part, and correct me if I'm wrong, in our last meeting, what I got from it is that we also have funds that are allocated through the ledge. Correct me if I'm wrong about that, Carolyn? Yeah? Or am I wrong?
Yes, so the state funds there, but to Leah's question, yes, in the context of DHMD, the Black Grant is the most steady sources of fund. And as you will note that there's a regular Black Grant, that's the one that we've been dealing with way before the COVID time. But after COVID, we have this and the mass violence around, then you have all this additional supplemental funds. So it has been an art and craft on on our leaders in terms of how they balance everything else. But while for those who are maybe lost in this process, like I am sometimes about this is just one part of what I call the planning. What is nice that I'm seeing this year is there's really a broader interest in planning more comprehensively, because that's, you've been asking for that. Where is the state comprehensive plan? But I think when Marian is saying, oh, we are looking at the budget at the federal state level, then that's really all part of how does the pipeline really look like? And is there something missing there? Are we trying our hardest best and then only to find that there's going to be a leakage somewhere else? So, all our efforts ends up not in. So anyway, so just rest assured that what I'm interested in right now too is to try to connect this mental health Black Grant mini proposal to the bigger state comprehensive integrated plan that the council really deserves also to take a look at when we have our act together. Thank you.
Thank you, Carolyn. And I'd like to recognize Marian Suji.
Leah, hi.
Hi.
To answer your question, Trevor Davis oversees 19 million that we got from SAMHSA. for the emergency response. And then we have smaller grants that we receive from SAMHSA for very specific projects. So there is other federal money coming in, but by and large, it's the block grant that's, that kind of funds us.
Thank you. That's kind of what I was wondering. Thank you.
I just wanted to add one more thing about areas that are of concern that are growing. Nationally, the forensics population has just been burgeoning, and I think everybody throughout the country is kind of dealing with this mental health, substance abuse, homeless population. And the courts more and more are mandating folks over into the treatment hospital side rather than the criminal justice side. And, the hospital right now is perfect example. I mean, our census is close to 400 right now. We're not equipped for 400 people. And we have many patients here that do not belong here. But be that as it may, the whole forensics area really seems to be an area that we need to pay more attention to. So we're really lucky to have Dr. Takanaka, since he comes from that side, to help inform how we're going to navigate this in the coming years.
Appreciate that. All right, thank you so much. Can I ask, detail-wise, what proportion or percentage of the block grant funds can be? Or AMD, I should actually say, yeah. Or do we know?
For you're asking is how much goes to CAMD and how much goes to AMD? Is that your question?
Well, overall, the whole budget, how much of the block grant is contributing to the budget?
To the
Because
budget.
in general.
I calculated that a while back. I can no longer remember. I have to go back and calculate it. But it's
I
not.
can
I can answer that
Yeah,
question.
go ahead. Yeah.
So I'm looking at my calculations. It's kind of there's a calculation that we use. Basically, 41.21% goes to CAMD and 58.79 goes to AMD.
Oh.
Of the total award. So
I think Dr. Omar was asking about how much, if AMD, how much is mental health block grant in our entire budget? It's not a very big amount compared to the state budget.
oh, okay.
But
I thought it was the division of funds.
Yeah.
Okay.
But
Sorry.
we're
No.
always
That's
we're always lacking money. So that's the reason why we have to chase the mental health block grant fund, but we also, our effort should not overly go through it. That with this, yeah. So yes. So we don't.
No,
I think I mentioned that before. It's not really the biggest one, but one of the biggest advantage, for example, during the COVID, because we had the mental health block grant, is when the federal government was ready to funnel money, you had that system, you had that infrastructure. So now we are able to receive all these supplemental funds. So that's the other advantage that I see, or the other value that I see in mental health block grant. It's not just the money.
No, I understand. I just want to know how much of it, because I'm thinking sustainment wise, right? A lot of that comes from the ledge and having that as part of the usual, but the block grant itself, yeah, I don't know how permanent those grant funds are often. So I was just wondering how much of the overall budget for AMD does the mental health block grant cover? And I'm thinking, since it's primary, I was thinking majority. So I'm not sure what percentage would be there. but I was just wondering.
Yeah, the
what-
table 2 will actually give you a glimpse of that, except I cannot pull it out right now because there's a column for state funds. So those are the ones that are coming locally. And then
Okay.
there's those column for there's a column.
Okay,
Yeah,
so
yeah.
that's significant. Okay.
Yeah.
Okay, not
So
table 6, but table 2.
Table 2 is the one that we take a look at. Yeah.
Okay, and then I have a comment for the forensics, but I've noticed Val mentioned that there's going to be a discussion regarding, especially I think table 6, right, regarding those funds. I'm not saying necessarily that the state council should be there, but I was wondering if it'd be possible to at least have an invitation at the table for that. Just in regards to where their money's going and to also learn a lot of the allocation process. If that could be something that could be considered, I think that'd be really appreciated just to be a part of those conversations. Yeah. Are there any concern over that? Yeah. Heidi?
May I ask a question as well?
Yeah, go ahead.
Miriam, you made a comment that the hospital is not the place for those forensic individuals. Where would you feel those people belong? Because I work for housing and I house a lot of those people, but there is that in between where they're not quite stable. So what's your
Right.
thought process on where they belong?
You know, in some instances, we have them here for a very short period of time just for eval. And it's kind of like we're a very expensive detox unit.
Mm.
And so I think this requires like a larger conversation between us and probably corrections. To really kind of think about creating something that is different than, and not quite a hospital, but not quite a correctional facility. Because I mean, when you're talking about hospital level of care, we're talking about some serious expenses. Does that answer your question, Heidi?
It does, and I'm in agreement with you. I feel like we don't have anything that's that in between right now. Certainly not on Hawaii Island where I am, but that's kind of the issue. And I work closely with a lot of the people in the court system, and they're struggling too. I mean, you're recycling people through the courts, through the hospital, through the courts, through the hospital, and it's this ongoing. They don't fit anywhere. So where do they belong, and how can we better? Because it's becoming a really growing issue. I see it in our community. And so the question is, what is the fix? Because right now I feel like everyone's like, not my problem. You know, like this
Right.
doesn't fit.
Not my
Doesn't
problem,
belong
but it's
here.
everybody's problem, right?
Exactly. And so I usually take them into housing when they become on, conditional release and all that kind of stuff. But before they get to us, clearly they have to go through, like you said, detox, stabilization, meds, there's a lot that needs to be done before they can come into housing and be successful. But we don't have anything right now on any of the islands, I don't believe, that I'm aware of.
When Belinda was talking about those licensed crisis residential services, would that be of help? Heidi and Marion, yeah.
Uh,
Can I say something?
Possibly.
Sorry.
Oh,
Yeah, we, I work for the judiciary. I'm the mental health court supervisor, the mental health unit supervisor, and that's the problem is we don't have enough of those stabilization beds, and they're usually allotted for like, people coming out of the hospital, like for certain ones, like example, if we're trying to get someone out of, OCCC to bring them into mental health court, or they're getting an evaluation, they have to go either to the hospital or like for OCCC, they can't just transition to the crisis shelter because it's
No, I
dependent
agree
upon
with
bed
you. I
space.
apologize for using the wrong term. You're right. But there should be something before stabilization is what I guess I'm saying. There's the hospital, there's the courts, the jail, and then there's stabilization and housing. And there's nothing in that in between. And I think we all agree there really needs to be something in that in between area that is, and I hate to say it like this, but a locked facility with, very strong needs to the individual who's going through medication issues, alcohol, drug, all of it. And we don't have anything, right? I mean, I don't think you guys have anything and we don't have anything. So it's this hole in the system right now that's growing, unfortunately.
Thank you, Heidi. Marion, did you have something you wanted to say to that too? Or
No, totally agree. And, you know, it'll be something that we're looking at for the upcoming legislative session.
do those licensed crisis facilities not offer those types of needs for like a health facility or no?
Behavioral Health Crisis Center is really for the immediate intervention. And
Okay,
it actually would
Before.
divert people from the criminal justice system, but there are people that are still going to make it into the criminal justice system.
I see. Okay. Thank you so much. The other thing I wanted to discuss a bit was we talked about the beds, but this has been something that the council has been discussing quite a bit. There's different types of beds, but also there's often not a lot of people to staff those areas and the need for workforce development and funds for that. I noticed Carolyn also brought up, you know, different training for Hawaii crisis counselors, a specific program in that regards. But I don't know if there's any more monies allocated to more programs that would help either increase the staff or retain mental health providers here to help staff for those areas, because you might be able to build them, but then how would they be staffed might be difficult. Yeah. Does anyone concur or add on to that? Yeah. No.
Totally concur.
Okay. Thanks. And then the last thing I wanted to mention was that question regarding the mental health block grant and what the state council's been doing in terms of preventative services for SUD and treatment. We've been talking about prevention a little bit, at least this past year, and I think it's important too to also be able to identify those social determinants that are contributing, because we can create a lot of resources to help meet those needs, and I think we do, but I also think it's a cycle like you were talking about in a pipeline. And being able to prevent a lot of these things from happening in the first place is a very essential part of increasing and maintaining the health and welfare of the state. So I think we've been on that track a bit of talking about social determinants and identifying those things and being able to provide resources that aren't just reactionary but preventative. But I think we still have a long way to go in that regards. Anyone on the council want to add to that? That's just my take on it. No one? Okay. Heidi, did you still have a question? I want to make sure, because if your hand's still up, I don't want to be ignoring you rudely.
I wanted to speak out
Sure.
on that issue, and that prevention is a very interesting creature. We are really unique in Hawaii in that we have a lot of wonderful organizations and people that care, but how are they reaching people? And it's really difficult to reach people. And how do we work together? And you know, I think that could be rolled into that that piece of the social media,
Yeah.
and maybe even including all the different agencies and groups on the platform with the American mental health resources that we had talked about. But it's as I started doing more research, which I'll share with the group later, it's a commitment to, because a lot of our messages are just getting lost out there and not reaching the right people. And there was a different block grant that was working on that through the Department of Health years ago, and I was involved in that project, and it rolled out. Took about 6.5 years for us to roll it out, but it's they're still looking at that, and I think that's a different grant. But yeah, there's definitely more work there. in relation to what you were talking about.
Another update on what you said regarding the workforce development. So we've now gotten workforce development grant, I think 2 years in a row, which has allowed us to pay our residential assistants, which is, you know, kind of the lower of the low of positions, a $4 increase. So we're one of the highest paid in the state, but it's solely on this grant. So if the grant goes away, then I would reduce everyone's pay by $4, unfortunately. So right now we're really thankful and grateful for it. But without it, it's taken me 3 years to get to a full staff. And I'm
Yeah.
still not, I don't have enough relief staff. I just have full. So we've been operating, you know, significantly at overtime hours on top of, you know, not getting an increase in pay in 12 years for housing, for, you know, staff. So significant.
Good point, Heidi. No, I think that rate study too, that has been allocated some money for will be helpful in establishing sort of that pay need and a benchmark. So thank you. I really appreciate it. And then for John, I agree with you in terms of messaging and social media presence. A lot of the resources that are available here, or I'm seeing many people, especially in the public, often don't know about them. And that can be an issue. And if there's something more that the council can do, I know we're already trying to work with MHA and with Brian to help develop that sort of resource that can help people connect more quickly and get a running list. I think that'd be great. I would argue and advocate that I would like the council to have more of that money, especially if we're going to develop that type of resource this year, as opposed to start a whole resource navigation system with half the budget we've been allocated in the past. So if there's something I can do to advocate for that, council, or any of us can do, please let me know. Does anyone else on the council see that as well, or would support that initiative? I don't want to be
I do.
Yeah, okay. And I recognize that Marion and both Forrest have their hands up, but Marion, yes, go ahead. Thank you. Thanks, John.
No, I was just going to add that Department of Health received a pretty sizable workforce development grant from CDC. So it's not just for mental health, but it's to overhaul and really develop the entire public health workforce. So there are a number of different initiatives that are coming out of that, including behavioral health development.
That's
so
great.
You know, there's that piece going on, and then this past session the ledge funded a task force to develop more peer mentors to help develop workforce as well, and that crosses departments. So it's criminal justice as well as I think DHS, DOH. So
that's really good news to hear about that CDC grant for workforce. That's great.
May I just share something? In terms, I do observe, actually follow about, because I'm also interested in communication. In terms of social media for mental health, the 3 ones that I have noticed, even in my own personal, social pages, very effective. Camdis, I think, because they have a Data to Wisdom grant, and they have a very talented and gung-ho person who's on top of it, or a team that's on top of it. So you'll see that. And that's the reason why they're able to also produce HawaiiHeal.org. The second one that I notice a lot, that has a lot of traffic, is your AANHPI, Ohana Center for Excellence. So they provide a very unique, information out there. And then Mental Health of America is actually the other one. So just FYI that if you're trying to look for ways to connect and all that, I find those 3 as very, very strong in the social media, have very strong social media presence. Thank you.
No, thanks. I appreciate that, Carolyn. And then I'd like to recognize Forrest and then Leah.
Yeah, sorry, I missed part of that because I had to step away for a patient care issue. But I guess if we're talking about prevention and working proactively. It'd be good just to see what what proactive things have been more effective in other states and been able to be implemented well, because there's such a wide gamut of areas that we could try to, put resources. And just in this discussion, the first thing that comes to mind, yes, the funding for the appropriate staffing and resources, but then also some sort of promotion to the education of that workforce, because I know just with recent hiring through Queens, we find that the pool is very, very small right now for the workforce, and the need is very high. So it might be even like at that level, not only just the recruiting or the making desirable jobs, but also promoting the education towards a career in mental health.
That's a good point. Yeah. No, I agree. And we can even partner, I can imagine, with the higher ed areas too, to help promote that. And I know even with the higher ed education institutions, one of the issues is getting them to stay here after, because it's so difficult to find the funds to be able to, in between license and graduation, to stay. I know there's been I know the recent ledge passing of bills and has, hopefully will amend some of those issues, but that's not even going to start till 2026. So there's still quite a bit of years that we have to work with that same system. Yeah, good point. Thanks, Forrest. And then Leah, I'd like to recognize Leah.
Yeah, so kind of relating to what Forrest and Marion were both talking about, when it comes to the career pipeline. So there's two issues, right? There's do we have enough prepared people to work in the system, and then how much we're paying them. But as far as the pipeline part, I sit on the State Workforce Development Council as well. And, that council is made up of people who are all interested in creating career pathways. So on that council, you've got the adult education, you've got the community colleges, you've got people from labor, different industries, unions, etc. And they're all interested in, what career pathways are needed and how can they help. So I'm just thinking it might be worthwhile for, I don't know, you chair or our council to reach out to that council somehow to start that kind of conversation. Just a thought.
No, thanks, Leah. If you can you can send me an email if you think it'd be best that I reach out. But I would be happy if they would come attend ours, or we can attend theirs to see what kind of partnership to develop, because that's a huge part, the development of the workforce and maintenance, and then of course payment. There's all those issues, right? So yes, if we can help with that, that'd be great, because that's one of the key, I think, components of making sure all these resources that go to building and addressing the urgent needs and the crisis in forensics are met with the proper, individuals that are educated and licensed to be able to do that. So if there's anything that we can do to help facilitate that. Yeah.
Okay, so I'll send an introductory email between you and the Workforce Development Chair, maybe, if that would help.
That'd be great. Thanks, Leah.
Thank you.
Yeah. Okay. Is there anything else?
The only thing I'll add in there is you might want to have a joint meeting with the Workforce Development Council, invite Washington State and how they've grown their behavioral health career pathways. He is a very good, that team there is very generous in sharing their information and honest also on how they did it. So just FYI, in case you want some speakers from the outside, we can certainly invite them.
You said Washington State.
Washington State, yeah. They were
Their
part
council.
They were part of our learning collaborative, and they definitely stood out across the nationwide, in the national scene, I should say, in terms
I'd
of
be
career
happy
pathways.
to. Yeah, I'd be love to be able to hear in terms of career pathways. Please, if there's someone you think I should contact, please let me know, or you can help me reach out. Yeah.
Yeah, will do. Thank you.
All right, thanks, Carolyn. Appreciate it. Yeah, having another speaker here would be great. Now, I recognize it is 10:18. It's been a while since we've all been on here. But before I we've had a very, I think, fruitful conversation and discussion. Is there any other feedback before I go to my next section here, which is really a break? Because after this is new business.
Maybe I just had a quick question, Chair, in terms of your process. So how do you want to bring back this conversation into your smaller committee?
Yeah.
To craft a solution or a response? Thank you.
A response, yes, I do, because now that we've actually brought it here to the council, I think most people were able to say very important things and have some feedback. I wanted just to take a moment to see if there's anything else, but then yes, in terms of process, you're right, Carolyn, it'd be appropriate, I think, for us to bring it back to the committee, which is Mary Pat, myself, and I don't know if Forrest wants to be part of it or not. I mean, he was there last time. You're feel free to join.
Sure.
Okay. Thanks. And we can bring it back and then craft the response, because I believe it's due already. Correct me if I'm wrong, right?
It's due, but like you have done in the last 2 years, we can always put it in the application to say your letter is coming forward, because we are already capturing the comments in the proposal, but your formal letter will come afterwards. Yeah. Thank you much.
Okay, great. Yeah, because I don't think it'd be appropriate to put the letter in now after we only received council feedback. And if I want to also make sure if there's anything else that anyone wants to write in before we meet, please do, because sometimes things take a moment to coalesce, have to think about. Okay. All right. I'm going to move to the next section, which is really a break. It's 10:20 right now. In terms of new business, we have quite a bit. So we have Trevor Davis and Dr. Eric Jewell, who will be giving presentations. So I want to make sure we give them plenty of time. And then after that will be our informational reports. I'd like to take a quick little break, but I want to make sure oh, I don't think he's on anymore. Oh, no, he is. Okay. Dr. Takanaka, I'm not sure if you would like to have a brief conversation during the break with me after, because I know you're here right now and you had brought up some things recent, yeah?
Oh, sure.
Okay, okay. So let's do this. Let's take a break and I'll come back at 10:30. Yeah, 10:30. Is that good with everyone? 10:30. Okay, better. Like to resume our meeting now, 10:30. Thanks everyone for hopping back on. So the order for our new business will be for Director Trevor Davis and then Dr. Eric Jewell. So they'll be our speakers, and then after that, we'll talk a bit about our informational reports. So aloha, Trevor Davis. We appreciate you joining us today. You've been here since the beginning, I think. Or is did he? Yeah, there he is. There he goes. Thanks so much. I know you're busy. I know too, you've done so much, and especially this last week, it's been quite a bit for the year since the Maui wildfire disaster, and you are the project director of the Maui Wildfire Disaster Response Project. I really appreciate all your work and your time here today to present to us and to the council. Do please, if you can, introduce yourself, and then you have the floor. Thank you so much.
Excellent. And mahalo for that gracious welcome. I appreciate that, Dr. Almer. My name is Trevor Davis. I am the project director for the Maui Behavioral Health Wildfire Response. It is the Department of Health's project for overseeing a SAMHSA emergency response grant. And so it's a federal grant that is initially set up for at least 2 years for wildfire response to enhance behavioral health services, but also focus on traditional healing, cultural practitioner services, hold wellness events and health fairs and things of that nature. Basically anything within, but also around the behavioral health realm that can help the community to begin its recovery process and continue its recovery process, which, as we know, is going to take many years. So this is just the beginning of it. But we are fortunate to have gotten some federal funding that is helping us to enhance the system of care, beyond just what the Department of Education and Department of Health are able to provide, we've been able to contract with many local providers, individuals in private practice, as well as cultural practitioners that have been engaged in the response since the beginning, since a little over a year ago. And it has been my honor to be over in West Maui, especially over this past week, to be part of the events for remembrance. And it was very impactful. It was, as you can all probably imagine, very intense in a lot of different ways. I think what surprised me out of it, if I can just mention that before I jump into my presentation that I have for you all, I think the thing that stuck with me the most was, despite the grief and despite the complex trauma, the amount of celebration at coming back together has been powerful and definitely impactful to a lot of folks. From the paddle outs, I'm sure you've all seen different media coverage and such, but what the media does a great job explaining, but like even as human beings, we have difficulty understanding is what it feels like being in those events. And so just the intensity of the feeling of being among all those people that were so relieved and happy to get back together. And even though there was sadness, it was sadness and some relief and some joy as well. And so as if the emotions over the past year haven't been complex enough, this past week has just been kind of that amplified. But I'll go ahead and jump into my presentation, but thank you for giving me the opportunity to say that, at least to get us started with kind of how that's been going. So I am admittedly not great with PowerPoint, so I hope that everyone can see this okay. The picture's a little blurry, but yeah, the whole presentation mode kind of throws me off. So I'm just gonna hope that this works well enough for you all. But yeah, Lahaina and all of Maui has done there's just been a lot going on with the ongoing recovery from physical property to emotional growth and folks just trying to stabilize. So for this first year post-disaster, we know that a lot of the early on problems were ongoing housing instability. Individuals, of which there were over 8,000 individuals displaced, and I've seen numbers all over the place, so forgive me if you've seen different numbers, but at least 8,000 people were displaced and into non-congregate shelters, as well as other housing with family members and such. And the frequency of moves that people have had to undergo post-disaster was extremely difficult, and the ongoing re-traumatization when people would get letters saying, well, we need to move you from one location to another, sometimes with 24 to 72 hours notice, not understanding the reasoning why behind that, and it not being fully explained by different governmental agencies. The letters weren't always clear that people were receiving, and sometimes it was just shoved under their door and no real knowledge of how to respond to that. It caused a lot of really significant layers of trauma. That even though people survived the initial disaster, they ended up being re-traumatized when they were displaced or uprooted again, and in some cases, half a dozen to a dozen times, depending on situations. So I've heard a lot of stories about people that really struggled to be able to maintain stability for their families, and it was extremely disconcerting to them. And as anyone who's taken care of any family members knows, a lot of people just turn to their family members and take care of them first, and then they themselves come last. And so we're starting to see more and more the impact of that. Intergovernmental communication was difficult. There were a lot of silos initially. But over time, those have broken down and improved substantially. There are a lot of intergovernmental and within the community partnership groups. There are committees, there are things that, there are work groups that either FEMA, the Red Cross, or other federal partners just kind of kicked off and got started. And then either the county or the state has continued running with, and some are community led and some are still government led. But the communication has improved dramatically among different partners because there's a strong sense of wanting to not duplicate services when the resources are limited. So we want to make sure that everybody involved in providing any kind of resources, whether it's through grants or whether it's through just expansion of ongoing programs, that everyone's communicating with one another. And I think we've seen a great deal of improvement in that area over the past year. And then outreach has been absolutely critical, and that is outreach from everything for where to get food boxes to where to get mental health or other health related services. You know, folks that lost everything were initially scrambling for medications and durable medical equipment and things of that nature. But over time, outreach then also picked up some of the other ongoing physical health needs that were becoming crises and having to intervene before they became full-fledged hospitalizations or other significant events like that. And then early on, a lot of the impacts were on education, especially to the teachers and staff at different schools. We saw a lot of dramatic impact on how the faculty were supporting all of their students and supporting one another as best as they absolutely could when they themselves were also in non-congregate shelters, sometimes 2 doors down from some of the students that they were working with. And so, you know, that has a psychological impact on folks that we've had to try and help people move through. And then transportation's been an ongoing difficulty, particularly for Kupuna. Anyone trying to get to medical appointments, anyone trying to follow up on hospitalizations, anyone just trying to be able to re-engage socially when they used to have their patterns of, you know, how their daily life went, and then that got completely disrupted. So transportation difficulties have been out there and continue, but have improved. And then the overall social determinants of health. There's just ongoing financial stress. There's ongoing housing stress. There's ongoing educational and vocational problems that are out there. And so a lot of effort is going into all of those different areas. Thus far, there was an immediate response where a lot of folks came from other islands. All the providers locally came together to really sweep in and do all that they could in the moment. And then on an ongoing basis, the first 6 to 9 months, there have been ongoing needs assessments and really trying to get the direct input of community members to find out exactly what it is that they feel they were needing. Just one caveat that I think is important to throw out right now is for the first survey at all in this whole first year that has just been done in the last month, this is the first time when needs of mental health have surpassed housing needs. So what that tells me is, since the non-congregate shelters closed approximately 2 months ago, housing is no longer the greatest need in some of the surveys that have been out there. Granted, the data sources are different, so perhaps I'm making unfair comparisons, but I think it's just an important note where housing has been anywhere from twice as much need to mental health to now people are feeling slightly more stable in housing or temporarily more stable in housing enough that they can start to address their mental health needs. And so that's going to lead to, you know, ongoing activities are focused on social and recreational activities, wellness activities, and building services from here. I've got a couple of slides of just different things that have been completed over this past year. A lot of grief support groups were created out of different partnerships in the communities. 988 had a critical role in helping support communities. And I know Belinda was on earlier, may still be, but I think 988 deserves a ton of credit for the amazing amount of work of standing up a crisis line in the midst of one particular part of the state's worst crisis related to mental health that has probably happened in a very long time is a substantial undertaking, and they've done a terrific job of responding to the community wherever they can. Also, over the past year, there's been the development of a certified community behavioral health clinic in Lahaina, and that was something that opened just after the fire. Within the first week after the fire, they just had their opening anniversary event this past week, and so those are ongoing services that are serving all populations regardless of ability to pay. And more folks are learning where that location is, just below the Civic Center. And there have been a lot more walk-ins. There are services available in multiple languages, and it's important that we continue to promote those resources. There have been other counseling services from private providers and community-wide, and then there are also group activities. So in some cases, people just want to be able to get together and talk story and not pursue what are considered formal behavioral health services. So there are plenty of options available for that as well. And these are just some of the examples that have been going over the last few months. And here are a few more. So even when non-congregate shelters were active, there were all kinds of different holistic approaches to addressing behavioral health needs. Sometimes it was just, let's get together and talk. But then there was also from our federal partners were driving the psychological first aid model as a community peer development model, where individuals could then come to a training and then teach one another how to use specific skills to approach topics around mental health with, less fear and less stigma. And so Wellness with Aloha was one of the programs that got developed as a cultural adaptation to the federal model of psychological first aid. And so some of those trainings are still going, but then arts and music became a very popular as well as very much needed outlet for folks. And so the Kanakapila Project, different activities through the Maui Arts and Cultural Center have all been extremely successful in the community. Building upon some of those events and activities, our emergency response grant is attempting to kind of go in a few different directions. And so we have added increased behavioral health support. I've got some data coming up on slides here in just a little bit. And that's for the formal behavioral health services, whether it be, some sort of group support, whether that's individual counseling, family counseling, et cetera. Some of the trainings for helping community members outreach to other community members, skills and resilience training for helpers. One of the lessons we've learned over and over again is our resources are limited. And when resources are limited, but the demand is this significant, we have to be taking care of our helpers. We have to be caregiving our caregivers and making sure that they're getting the opportunities to recharge, that they're getting opportunities to enhance their skills, and that they are learning new ways of being able to approach the community as well. We are in the process of working with community partners and a locally grown board to create a resiliency center, a community resiliency center. It's going to be located in Ka'anapali, and we'll talk about that more in just a moment. And then as far as wellness activities and events, on August 26th, I did not get the flyer before this meeting started, unfortunately, but I will make sure that it comes to this group as soon as I get it. That on August 26th, Papa Ololokahi and a lot of other community partners, including the Surge or SAMHSA Emergency Response Grant Surge Provider Network, are coming together to host a wellness fair on that date. It's a Monday, and I believe Napili Noho is hosting that. And so when I get the flyer for that, I'll make sure that that comes out. But there's going to be a lot more of those types of events and the activity and activities going forward. So we're just learning the best ways to communicate that out to everyone going forward. We are still focused on building up our ability to train community members to help one another. That's one of the things we've heard loudly and clearly, And when we know we don't have enough professionals to cover all of the potential needs and demand on a day-to-day basis, having community members trained to be able to help one another until professional help is available is critical. And so we're working to develop a long list of different trainings. We're also partnering with different parts of the Department of Health, CAMD, ADAD, and AMHD for the trainings that they're providing through other grants and their own programs, so that we can have what we hope will be a comprehensive offering to a lot of folks that want to just do things their own way, because recovery is different for every single person. And so we need to be offering as many different options as we can. And anytime we think we've got everything covered, we need to expand it some more. So that's the thing that I think we've learned over and over again. If I can share just some data quickly, I want you to be able to see that probably February into March is when a lot of our surge contracted providers got up and running. They'd been providing services prior to this, but as far as grant funded and formally as part of our grant for tracking purposes, a lot of that kicked off with the contract establishment in February and March. And so you can see the data month to month of individuals served, families served, actual clinical appointments versus receiving some sort of support services, or traditional healing, cultural holistic practices, wellness events. We've kind of broken things down in a few different ways. I know that probably there would be a lot of questions and probably a lot more explanation available for this if I had more time, because data always tends to prompt a lot of questions. So I apologize if I've caused a lot, but I'll try and get to those when we get to the end. And then events hosted, those are wellness fairs and types of activities where they're going into the community and approaching small groups of folks, sometimes on a neighborhood by neighborhood basis. We've produced some materials, held some trainings, but that's all sort of grant activities thus far through the end of June. I'm just working through July's data from our provider partners now. And then this is just a quarterly summation of the same information, but you can see this strong jump in April to June. And that, to me, the quarter two data is going to be more of a similarity to what we're able to provide over the next year to year and a half, quarter to quarter. That first quarter, we weren't complete in our provider network yet, and we were still getting things up and running. It was a transition period. So I consider quarter two the baseline data, and that's what we're going to be building on going forward, just so that everyone's aware of that. Just some other ways of looking at kind of some of the same data. This is for all populations, individuals served by the different providers. And this is a list of providers that have done things up to date. We keep adding more providers and services wherever we can. This is not an exhaustive list, but this is a list of all the folks that have been able to track and provide us data thus far. But we are doing whatever we can to have a very mixed approach as far as just typical formal behavioral health services, where it would be like a billable service, versus something that's more of a supportive event or activity for wellness. Families served by provider groups. So this is more aimed at actual children, adolescents, and overall their parenting, their family, parenting families as well. But the numbers are pretty substantial and pretty well decently going up from month to month as well. So that's exciting. And then this is just a summary of clinical and non-clinical, kind of the number of appointments that we're seeing, keeping in mind that appointments don't cover everything the grant is doing, because there are other activities that are not appointment-based. Anything crisis-related does not count in this. And this is separate from any of the formal data that would come out of the Department of Health divisions as well. So this is all just providers for this grant that have generated these numbers, just so that that's clearer. Events hosted, we're trying to just kind of get some more qualitative data behind these numbers so that we can explain the story of why hosting events and bringing people together is more impactful in a lot of ways for a lot of people than just providing services. I think kind of the meat of what I wanted to get to was just what we've learned thus far. outreach has been critical, and we have to have coordinated communication among state and federal departments, or we don't respond effectively. And so, I mean, that may be kind of a no-brainer to most people, but it is amazing how hard that can be when it's groups of organizations that haven't necessarily formally worked together on anything, to have to come together suddenly and figure out how to work with one another. It's can be surprisingly challenging. And then crisis response and education, there's been so much work done in that area, and I think it's been very effective. As far as ongoing challenges, we need to continue to approach any type of recovery offerings that we make, whether they be events, whether they be trainings, through the appropriate cultural lenses. And so, you know, there have been offerings from all over the country, all over the world of, we could come in and provide you a trauma training on blank. We could come in and provide you information on how to recover from grief. And when we come back and say, great, what are your cultural approaches to working with the following populations? They blink a little bit. There's a moment of pause in those conversations, as you know, one might expect when they're, you know, nationally normed and all of that, you know, this is a different group. So we just have to make sure that we're focusing on making sure that cultural sensitivity is involved in every single thing that we're trying to offer to everyone. And then the social aspects of things have been critically important. Sometimes doing a recreational activity has far more attendance and far more impact in people's recovery than I think we could possibly anticipate. Perfect example of that, weekly bingo with Kapuna has been one of the best attended events of anything that happens. And having seen it at the anniversary event, where there were over 100 people dressed up really nicely, and they liked seeing the hula and they liked listening to the music, but after about an hour and a half, you could see some faces getting serious, like, let's get to the bingo. That's why we're here. Let's go. And it was great seeing that level of socialization. It was very encouraging for me. We have to reframe behavioral health on an ongoing basis. There's still a lot of stigma, both within families, within cultures, within the overall community. And as much as we put effort into, you know, demystifying wellness and how that goes, reframing things so that we're not talking about come get counseling, but it's come talk story, where it's tell the stories of your recovery. Let's talk about successes, but also what might still be challenging for you. Those sorts of things have tremendous impact. And then we have to maintain a focus on making sure our helpers are well taken care of, because compassion fatigue is a real thing, and it is chronically coming up. I think this week, after all the remembrance events last week, I think a lot of providers are taking a breath or 60, just trying to recover from everything that came at them this past week. Really quickly on the Resiliency Center, in Ka'anapali, we're about 2 to 2.5 months away from opening a center that is going to focus on healing and be a gathering space. It is not going to be specifically, this is just another presentation of similar information. It's not focused specifically on formal behavioral health services, though those will be offered. But a community-based peer support is going to be a big part of this. Having traditional healing practices and events taking place. There's both indoor and outdoor space on the site. And then having wellness fairs, community events, and then trainings for our skilled helpers, as well as for community members, that's all kind of within the realm of things. There's even talk of Kealoha, the Resiliency Center that will be opening in a couple of months, adding a therapy dog training program. They're talking about all kinds of different holistic opportunities for this Resiliency Center to make it a long-term, if not permanent, fixture within the community, where people know they can go to at least get started with figuring out what they need. If nothing else, it's a starting place. So as that opens, there will be a lot of marketing work around that, and hopefully we can encourage people to use it. So these were just my overall takeaways of, you know, it's the recovery is slower than anyone would like it to be. And that's just sort of unfortunately the reality of this kind of a disaster. but hopefully we can focus on shifting everyone to post-traumatic growth, continuing to communicate, and then helping to prevent the burnout of our providers. And I am going to stop there and open it up to questions. Hopefully that was helpful.
incredible. Thank you. Thank you, Dr. Davis. That was great information. So much data, great lessons learned, great takeaways there. Really appreciate your time. I'm gonna open it up to everyone. Does anyone have a comment, a question for Dr. Davis? No? Oh, sorry, John. Saw you up there. I recognize John Fuji.
Thanks. I'm trying to be better about raising my hand in meetings. Kelly's laughing because she
You're
knows
doing
sometimes I don't. Hi, Dr. Davis. Really appreciate your presentation. I just so many questions, so I gotta try to think about what I want to ask. I work for Medicaid, so of course integration health plans. As you're talking through this, I'm processing around, okay, like, what is and you talked about communication between entities, right? And so this is me trying to communicate to you, I guess, around like, what are the ways that you see that our Medicaid health plans can be a part of this process or be helpful to the process, or can collaborate with one another to be helpful to the process?
So I can tell you from meetings I've been a part of with the Governor's Office for Wellness and Recovery that one of the things that keeps coming up for health plans, particularly with Medicaid, is just the credentialing process for providers is, I'll say challenging. They use stronger words. And so there's just a lot of feedback that it would be beneficial if there were ways to potentially expedite or get more assistance along the way in applying or reapplying for credentialing of providing different services. There are a lot of community providers that would like to be on more health plans, but don't feel they have the time to be able to put in all of the effort and the ongoing and overcome the ongoing challenges of just kind of working through the bureaucratic process, which has to be there because you're under federal regulations. And so, you have to be careful who you're credentialing. So obviously you have a ton of responsibility there. But I think that's one way. And then anything that can be done to support the training, both skill development wise, and then, burnout for providers is huge. And so for anything that Medicaid health plans can do to support the ongoing professional development, whether it's paying for a trainer and inviting credentialed providers to trainings, things like that, lunch and learns, even if it's just bite-sized little trainings from time to time, I think that can be extremely beneficial. If I thought about it more, I could probably come up with a longer list, but that's just off the top of my head.
Yeah, no, I know you're super busy, but like I want to understand more and get your thoughts. So if you want to put your thoughts together and send me an email, I would really appreciate that, because that's something I want to make sure, our health plans are. I know when we first started, but when the wildfires first hit, and I know our plans are really on the ground doing a lot of things, but not you're talking more about sort of like more extended sort of like the rush of the the pandemic, or not pandemic, the emergency sort of subsided, and you talked about moving on from housing to more behavioral health. So just I think it's a little bit new, sort of it's transitioning, right? The need is transitioning. That's what I heard you say. So to the extent that we can continue to be, and our plans are good. In my opinion, I thought they did really well in terms of like first 2 months, going door to door, knocking on doors, not caring about if it's their plan or not their plan, right? So, but so wanting them to continue to be part of the solution and helpful where they can be. So yeah, if you could, I would appreciate an email from you about what your thoughts are around that, what that looks like.
Yeah, I'd be honored to. Thank you.
And if I have one more question. So you talked about that wellness center. Can you tell me a little bit more about that? In other words, sounds like you folks have a place, and you sound like you have some programming. I mean, how is it funded? Is surge funded or grant funded? Is it time lapse, or how does it work?
So it is primarily funded by Maui County. They funded the first year of operations, and then there are community charitable organizations that are co-funding that as well for the first year minimum. And then currently there's a group of kind of grassroots work group that is coming together to try and fund it for years 2 through 5. Both through the county, but also through other partnerships. So it's separate from any government or grant on its own. And it's mostly through a lot of charitable organizations. I've got a one-pager on it that I'd be happy to send you so you can see some of the partnerships that are developing it. And then that way you can see kind of exactly what's coming out of that. So
Yeah,
and
that'll be
and
helpful.
yeah, and I think it's probably important to have that as well, just because resiliency center, wellness center, resource center, those terms are getting thrown around a lot on Maui. And I think there's probably thoughts of that there may be 5 or 6 different ones going when there kind of is, but kind of isn't. They're all doing slightly different things because we're all trying to work together to not duplicate. But definitely, I think explaining it more effectively will be beneficial to everybody. So I'm happy to send you that too.
And the reason I ask about that is because Medicaid's going to be, over the next couple of years, making available funding through POL, Papa'ololokahi, to do things related to improving Native Hawaiian health and healing. And so this sounds like it's right in that wheelhouse of that population, and sort of improving health, and going down and now they're coming out, and so continuing that upward slope of sort of improving the overall health of the population. So okay, thank you so much. We appreciate your time.
Yeah, thank you.
Thank you, John. And before I move on to Mary Pat, I want to just say Trevor did put his email address in the chat, John, or John, you can also put yours in the chat so you can both connect. And if you can, Trevor, really would appreciate also getting, if you can, that one pager as well. I'm not sure if you're allowed to share your slides. If that is a possibility too, would love to be able to see that.
Yeah, I'm happy to. Yep.
Oh, thank you so much. Thanks. And then I'm going to move now. Thank you, John. I'm going to move to Mary Pat. Yeah, go ahead.
Thank you, Trevor. That was very informative. The question I have, I'm not too sure if you have the answer for. And what I've seen in the news, like you said, is these people move like 5 or 6 times, like all of them. And I'm wondering why that is.
So a lot of that was, initially it was get people into rooms as quickly as possible so that there's some sort of shelter for families. And then as time went on, people sort of shuffled around a little bit, because if you were a family of 6 in one room and there was just a single person in the room right next to you, and a larger room happened to become available because someone moved either in with family or off island or something along those lines, then they had to start shuffling people around to that. So they were moving larger families into the larger spaces whenever they could. But unfortunately, what that meant is a lot of those decisions were made without family members being engaged and involved in that. And so they would just get a letter telling them they were moving rather than asking them if they'd like to. And so, when you're dealing with thousands and thousands of displaced individuals in a small area geographically that have, there's a ton of resources in a very small area. After a while, it just becomes sort of a bureaucratic process, unfortunately, and people get kind of lost in that, and their input wasn't as considered as it could have been. I'm understanding that that's how it works in most of the disasters, that's how it goes with Red Cross, FEMA, with and then Hawaii Emergency Management as well. But I think people tried to be as compassionate as they possibly could, because there were people behind all of these processes that really cared and really were passionate about trying to help in whatever the way they could. But sometimes bureaucratic processes get in the way of our compassion, and so it resulted in some unfortunate outcomes for some folks, in that they became more distressed, that some people were just worried that they were going to walk out into their living room and see a letter slid under the door, and they're just waiting for that to happen. And unfortunately that did occur for some folks. And so it's just hard, and it's just, more unplanned change when you're seeking control over anything in your life at that moment, right? And so it just really caused some additional problems for a lot of people. But most people moved at least 3 times, and there are a ton of reasons for that, especially because this is probably the longest shelter response that our federal partners have had to deal with in a very long time. And so I think that they may be making some future adjustments to how they handle long-term things like this based on what they've learned here. And then they also have their ongoing processes to maintain. So we'll just all hope that there were some lessons learned on all the ends, just like we had a lot to learn too.
Thank you.
Thanks for that insight, Trevor. Thanks, Mary Pat. And I just want to recognize Kaylee Aquera also mentioned that CCBHC will be trying to collaborate and build with the health plans. I'm not sure if networking altogether, John, Kaylee, and Trevor would be helpful. Yeah, so if you want to put your email in there too, Kaylee, feel free. Yeah. And John, you still have your hand up. Not sure if you still have a question or no. Okay.
Yes, I do.
And then I'll move. No, actually not. Yeah, sorry. The other John for GE. Sorry,
John.
I'm going to go. No, it's all right. Sorry, John. I'm going to go first to Dr. Reese and then to you, John. So thanks so much for your patience. Dr. Reese, go ahead.
Hi, thanks. Trevor, thank you for your really great presentation. I'm Dr. Reese. I'm a clinical psychologist based in Honolulu, and previously was very active on this council, and I was chairperson of this council earlier. First of all, I want to commend you guys on including the awareness of the importance of focusing on cultural practices, and also on the possibility for compassion fatigue for providers. What we see a lot of times, we see after there's sort of an uptick in mental health problems in the population, maybe 6 months in the aftermath of that, we see an uptick in problems with providers. And so I just wanted to commend you on that and thank you for your presentation, and also mention that if there's a role for me to be of use to you guys as a consultant, or even to conduct some kind of a training, I'm certified by the Green Cross and the Figley Institute as a compassion fatigue educator, and have a lot of material sort of already at my disposal that could be easily put together into something meaningful. So I wanted to invite you. Carolyn, are you still allowed to pass along my contact information?
Of course.
So as things develop and as things unroll, I'd be happy to be helpful in some way. But excellent work. So thank you.
Thank you. I will just caution you, be careful what you volunteer for, because I will take advantage of that very much. So thank you for offering it. I think we need every resource that we can get for our providers over there for sure.
I'll be honored to collaborate with you guys, and I think you're doing really great work.
Thank you.
Thank you, Dr. Reese, and thank you, Dr. Davis. All right, I'm going to move on. I just want to be mindful of time. We are at 11:11 and we do have 2 more speakers. Thank you so much for this lively conversation. I'm going to, our last question for John to ask. Yeah, John Betlock.
Yes, I also wanted to reiterate that the cultural sensitivity, very crucial, and the alarming the population as well as the providers, very, very good. And I also was going to say to what John was talking about, which was the holistic center. We've kind of been having a talk about how there's a need for how do we address group work, like support groups or group therapy groups, and even if with a cultural practitioner, to fund those. So that would be something that I would look into in the collaboration, John. The Center of Excellence might provide some support there, because I know that they're integrating that piece right now. And yeah, just leave it at that. Thank you.
you so much, John. It sounds like, Dr. Davis, you have a lot of volunteers that are ready to collaborate. So
I love it. I love it. I didn't come here soliciting them, but I'm more than happy to walk away with some new friends. Thank you very much.
No, thank you for being here. Really, really appreciate it. And I'm going to, please feel free to share those slides. We really appreciate that. And again, huge mahalo to you and all of your work. Really appreciate the time and the information you have shared with us today. It has been very enlightening, and hope you can see more of you again soon. Thanks so much. All right.
Mahalo.
Mahalo. All right, and I am going to, thank you so much. I'm going to move to Dr. Jewell, and I believe he's our next speaker. And then be mindful of time. I know we end at noon. We have another for reports here, but thank you so much for everyone for your engagement. Really do appreciate that. All right, Dr. Jewell, thank you so much for being here today. You're going to give a little bit of background in terms of different types of TMS, or at least different information regarding TMS, its treatment, its outcomes, its evidence. And we've heard a lot about it on the council, but don't know too much about some of the background. So we really appreciate you coming here today and giving us some of that information. So please, Dr. Jewell, if you can introduce yourself, and you have then the floor. Thank you so much.
All right, thank you. Very welcome. And thank you for having me here. Dr. Davis, thank you for the update. That's critical information for the ongoing support of folks in Maui. It's good to hear this information so we can continue to orientate efforts. I'll give me a moment to set up my slide here. Make sure I have everything going. Okay, there we go. All right, and again, aloha awakea kako. Good morning, good day, everyone. Thank you for having. It'll be myself, and also Dr. Brennan Friedman will be co-presenting with myself. Thank you, Dr. Davis, again. Special thank you to the Hawaii State Council on Mental Health, and to Dr. Richard Reese for this opportunity, and then also to Carolyn Wiegand Hildebrand for your support. Generally, thank you all for joining us today. It's my first time attending one of these council meetings. I'll be back. This is a wonderful community of people, and I'm excited to be here to present, and I'd like to be here more in a capacity to learn and collaborate as well. My name is Dr. Eric Jewell. I'm a clinical psychologist and co-owner of the Hawaii Depression Clinic. With me again is the wonderful Dr. Brennan Friedman, professor at UH Manoa, also our medical director at HDC, and one of our prescribers of TMS, transcranial magnetic stimulation. Today, we are excited to talk to you about TMS, which is a safe and effective way of treating people with different mental health disorders or conditions, specifically depression. We'll spend about 20 minutes today explaining about how TMS works, its benefits, what you can expect from the treatment, and after that, we'll be happy to answer any questions that you might have. Prior to beginning, I'd like to honor some of the providers that are currently in the community, currently practicing, such as Dr. Cecilia Ona at Kahai Mohala, Dr. Doreen Fukushima at Ho'olopono, Dr. Thomas Cook at Beyond Mental Health, and Dr. Jason Kiefer at Brain Health Hawaii, amongst others in the community. There's a vibrant community of providers that supports TMS across the islands, and at HDC, we're honored to contribute to the education and awareness raising that's come before us by these pioneering individuals. And then again, thank you all for being here. We look forward to sharing this important information for you. Taking a look at our outline for today, briefly, Section 1 is related to understanding TMS. Section 2 is about TMS and depression. Section 3 is about recent developments in TMS. And then Section 4 is about next steps to take, and then what to do with this information. Finally, a Q&A at the end. And so in understanding TMS, transcranial magnetic stimulation is a non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain in different areas. Involves placing a magnetic coil on the scalp or cranium, outside the scalp or cranium, to deliver the brief magnetic pulses, which can help improve the symptoms of depression and other neurological or psychiatric conditions by modulating or regulating brain activity. It's considered to be a safe and effective way to treat a variety of conditions. TMS does have an interesting and transformative history in the field of mental health. It emerged in the mid-1980s. Dr. Anthony Barker was an engineer by training, and his colleagues first introduced a magnetic stimulation device at the University of Sheffield in England. Initially, the focus was on brain mapping and mapping brain function in peripheral nerves, but he and others quickly realized that TMS had potential for therapeutic application. The technique gained significant attention in the 1990s, and studies began to explore treating depression. In 2008, the FDA approved the first TMS device and protocol for treating major depressive disorder in patients who had not responded to traditional antidepressant medications. This marked a major milestone, making TMS a recognized and viable treatment option. So how it works. Our brain communicates through electrical signals, and sometimes, especially in the case of depression, certain areas of the brain may not be as active as they should be. And again, TMS involves placing a magnetic coil on the scalp or cranium outside the cranium to deliver brief magnetic pulses, and it will target specific areas of the brain to stimulate them, to normalize or to regulate brain activity. Conversely, TMS can be used to decrease brain activity in areas that might be overactive. And so when we talk about TMS, one important factor is the frequency of the magnetic pulses that are being used during treatment, or high frequency and low frequency. Of note, the on-label use of TMS would mean the FDA cleared protocols for major depressive disorder and obsessive compulsive disorder. And this would be the high frequency treatments. Low frequency treatments would also be considered, would be considered off-label. However, there are studies and protocols that show promise in their ability to treat a variety of experiences and disorders. So with high frequency TMS, that usually means that pulses are delivered at a rate of 10 hertz or higher. This high frequency stimulation tends to activate or excite the brain cells or neurons. It's like giving them a gentle push to get them working better. This type of TMS is often used for treating depression, especially when targeting the left side of the brain's prefrontal cortex, or the dorsolateral prefrontal cortex is the area that's indicated here. Low frequency TMS, on the other hand, typically involves pulse rates at 1 hertz or lower. This frequency tends to have a calming effect, reducing the activity of the brain cells, and can be particularly useful for conditions where there is too much brain activity or hyperactivity, such as anxiety disorders or certain forms of schizophrenia or trauma. By calming down overactive areas of the brain, low-frequency TMS can help reduce the symptoms such as excessive worry or agitation, amongst other experiences. And so the choice between high-frequency and low-frequency TMS depends on the specific needs of the brain in different disorders. High-frequency TMS is like giving the brain a boost when it needs more activity, while low-frequency TMS is hitting the brakes on the brain when it's overactive. This tailored approach helps make TMS be a versatile and effective treatment for a variety of mental health conditions. TMS is safe and effective, and for many folks, it's not a silver bullet, it's not everything, but for a lot of folks, it is an important something, and it is generally well tolerated with a few elements that can be challenging. Challenges or side effects that patients might experience during the session or just after the session. And some of the common issues would be mild to moderate discomfort or pain at the site where the coil is placed, often described as a tapping or tingling sensation as the magnetic pulse is delivered through the cranium. For some, this can be discomfort. That can be significant for some, but usually decreases over the course of treatment sessions, especially as the nerves in the cranium or scalp get acclimated to this novel stimulus. Headaches are one of the more common side effects of TMS as well. Generally mild, can be managed with over-the-counter pain medication, and typically lessen as the patient gets used to the treatment as well. The scalp and forehead may become sensitive due to repeated magnetic pulses. This can cause discomfort during and immediately after the sessions. We can work to adjust the position of the coil or the intensity of the pulses to help to alleviate this sensitivity. The magnetic pulses can also cause small involuntary muscle contractions in the face or the scalp, typically harmless, but can be uncomfortable or distracting for some patients. Additionally, as the magnet is delivering the magnetic energy, that it will turn on and create a clicking sound, creating some hearing sensitivity. It can be loud, might be bothersome for some patients. Some people enjoy it. So we can offer earplugs during treatment to help reduce this noise. Some people report feeling tired or fatigued after a TMS session, typically temporary, and it can be managed by scheduling sessions at a time of day when people can rest afterwards. But you can drive yourself to a session, and you can drive yourself home as well by yourself. In rare cases, TMS can cause more serious side effects like seizures, especially in patients with a history of epilepsy or neurological conditions. However, with proper screening and following safety protocols, the risk of seizures is very low. There's different TMS systems with different safety parameters. We use NeuroStar system, and that is 0.01% or less per patient statistically that could cause a seizure, so quite low. While these challenges exist, these symptoms or these experiences, many people find that the benefits of TMS in improving their symptoms outweigh the discomfort. Particularly, people often come to TMS as an alternative treatment where other treatments have failed, or treatment-resistant depression. Clinicians with these symptoms can often adjust treatment parameters to improve tolerability and reduce side effects, making TMS something that is a viable option for many individuals. Next up, we'll invite Dr. Brennan Friedman, our medical director and prescriber of TMS, to share more about TMS and the treatment of depression. I'll turn it over to you, Dr. B.
All right. Thank you so much, Dr. Jewell. Appreciate it. And hello, everybody. Thanks so much again for having us here. It's really a pleasure. And I think it's really fitting that we're talking about this, especially since we were just talking about the Maui fires. I have deep roots there as well. Really appreciate the conversation and the resources that were being discussed. That was awesome. So just to back it up, because I know this is a public forum about major depressive disorder, MDD. That is a persistently depressed mood lasting a minimum of 2 weeks. And I think we can all gather the symptoms that can present here. Anhedonia, we don't like that one for sure. That is a loss of pleasure in something that was pleasurable at some time. Hopelessness, fatigue, sleep disturbance, guilt, changes in appetite, feelings of hopelessness and worthlessness, persistent thoughts of death or suicide, inability to concentrate or make decisions, change in physical activity, and the list goes on, of course. And next slide, please, Dr. Jewell. Appreciate it. I'm going to pass on this one in the interest of time, just to let you guys know. I know you guys, there's a lot of specifiers out there for major depressive disorder. And some of the ones that we really consider in TMS is severe, moderate, and mild. Most of our patients that we are treating have moderate to severe depressive symptoms. And we'll talk a little bit more about that as we go on. So next slide, please, Dr. Jewell. Thanks so much. Appreciate it. And just backing up there, I know I'm speaking the choir on this here, but major depressive disorder. Depression is #1 cause of disability globally. Lifetime prevalence rates to over 20%, 2 times greater risk for women than men. But of course, that's with what is reported. And I'm always a big fan of, I think it's very underreported in all populations, but I think we have a lot of room still left to go for men to come forward and feel comfortable talking about the symptoms that they're experiencing. Our LGBTQ youth, 58% experience depressive symptoms. We really have some work to do as a society for sure. 50% have an age of onset between 20 and 50, the mean about 40 years. 70% of individuals with depressive disorders have comorbid anxiety symptoms. And so that does really play into what Dr. Jewell was talking about before with the different frequencies that we can use. It's not a one-stop shop kind of a treatment. We can curtail it and tailor-make it for all of our patients that we have, because there is so much comorbid anxiety that goes on amongst other diagnoses and symptoms that folks experience. And this article, I just wanted to plop it up there for you guys. I thought it was interesting. I teach nursing for our pre-licensure students, and I'm always into the articles that come up, but this article looked at the prevalence globally, and it was interesting that the highest rates are generally in the most wealthy countries. Lots of different reasons why that may be. And next slide, please, Dr. Jewell. Thanks so much. So treatment of depression with transcranial magnetic stimulation. As Dr. Jewell was saying, we're stimulating the left dorsolateral prefrontal cortex. We generally start with that with most of our patients. And we do see some effectiveness for not just depression, but for the anxiety as well with that. So we'll start off with that and see how everything is going. Our outcomes have been really good. And I got to tell you, it's not on the slide here, but just as a prescriber myself, to see the outcomes that we're getting without needing to prescribe additional medications, uh, and having such good outcomes with such little side effects, is just a remarkable thing. It has been just a pleasure to see folks grow, and them get better is just a beautiful thing. Uh, it is involved with, and that's supposed to be underneath the left dorsolateral prefrontal cortex, but that section where it's supposed that it's involved with mood and depression. That's why we're treating that particular area. Decreased activity during depressive episodes. I have a slide right after this just to kind of show that on a PET scan. Possible mechanisms of action, synaptic plasticity, neurogenesis may promote changes in dendrites, assisting in regulating chronic stress and depression, and neurotransmitter release. And now we're talking about all those good ones there: serotonin, norepinephrine, dopamine, all of that good stuff. And next slide, please, Dr. Jewell. Thanks so much. And this is just a quick visualization of the brain. This was provided by NeuroStar, just letting you guys know. And it's a PET scan of the brain activity that's going on when somebody is depressed versus when somebody is not depressed. And of course, we all know that there's different causes for the symptoms that present, but by and large, in general, this is what we may expect to see. And next slide, please, Dr. Jewell. Thank you so much. Some of the treatment comparisons, and this is not tit for tat saying it should be this or that. This, you know what? I'll go straight to the bottom bullet right there with, there's a lot of room for concurrent treatment modalities. I love the fact that almost all of our clients are receiving therapy as well as the TMS. In conjunction, it's a beautiful thing. And we have a lot that are on medication as well. And one of the things that we're always trying to strive for is consistency as we're going through the treatment, because the treatment is long. It's a long, my heart goes out to everybody that's having the treatment for sure. They are very motivated to be well. We're talking about 6 weeks, 5 days a week, and then we taper down for a couple weeks after that. So, you know, they're putting a lot of time into this. So therapies, of course, so many different types: CBT, interpersonal therapy, behavioral therapy, group therapy, all really very valuable. Medications, SSRIs, SNRIs, and SNDIs, all of those acronyms, TCAs, MAOIs, not so much anymore, but we have some folks that are still on MAOIs. Ketamine and S-ketamine, that's big news, and that's a whole nother topic for us to talk about as well, of course. Benzodiazepines as well. Electroconvulsive therapy, another comparison. And the interesting thing is with ECT is you are trying to have you're trying to cause a seizure in a very controlled environment. In this particular treatment, as Dr. Jewell was saying before, it's very low risk of a seizure and on par, if not lower, than most of the psychotropic medications, which I find that just a wonderful thing too. There's other treatment modalities as well. Vagus nerve stimulation is having a lot of push right now. Biofeedback hypnosis, dietary herbs and supplements, and hypnosis as well. And again, like I was saying, with that that last bullet, which I started with, the concurrent treatments, I think it's a beautiful thing, especially with a therapy is a wonderful thing. And next slide. Thank you. Just a quick picture of some of what we can expect sometimes when we're prescribing. It takes a number of times, especially for somebody where it's the first time we're prescribing a medication. So just to look at some of the effects, the likelihood of remission with each new antidepressant actually goes down as we're going on and trying. And I think, as we know from what happens out there, is it's not, you're lucky if you find the first try with a new client who has not been on a medication. And then on the bottom of that slide, we're talking about increased side effects with each new antidepressant, and actually goes up as we try different medications. And that was just to compare. And again, the thrill that I have as a prescriber to have a treatment regimen where medication has not been the one size fits all, solve every problem, and have a treatment regimen that has such few side effects with such great outcomes has been remarkable. Next slide. Thanks so much. And just another quick slide over here. And I do have to point out that this is data for the NeuroStar system. There are other systems that are out there, and I want to, there's other great systems as well, but this is the NeuroStar data that we have, that we find an improvement in depression symptoms, 83%, and then 62% of the folks that we treat find remission, which is pretty remarkable when you consider about the remission rates that you may have from medication alone or therapy alone. And when you commingle those, my goodness, it can be really impressive. And this has stayed true to what we have experienced in our clinic as well. And next slide. All right, and back to you, Dr. Jewell.
Going to be for me. Thank you, Dr. B. Prior to getting to our next section, our call to action and suggestions for next steps, I'd like to take a briefer look at current developments. I know we're a little short on time, but current developments in the field of TMS. So recent developments, NeuroStar, the company that we use, I think they're a pioneering company in TMS technology. That's why we like them. But they recently received FDA approval for the treatment of major depressive disorder, MDD, in adolescents aged 15 to 21. The study was for 12 to 17, but the FDA approval was for 15 to 21. Helpful. It expands the availability of TMS to a younger population that often faces limited options for treatment-resistant depression. Also, recent studies have focused on optimizing treatment protocols such as accelerated TMS, which involves several sessions per day. Stanford has a SAINT protocol, sessions throughout the day, really, that show promising results in reducing depressive symptoms more quickly. Also, research exploring TMS for conditions like generalized anxiety disorder, obsessive compulsive disorder. FDA did approve TMS for OCD in 2018. And ongoing studies aim to refine the targeting for these areas, the stimulation parameters for these areas for better outcomes. Briefly, in terms of precision medicine, this is something that Brain Health Hawaii does, is using neuroimaging for brain mapping activity. Clinicians can more precisely target areas involved in patient-specific symptoms, potentially enhancing the efficacy of TMS. And also biomarker development. Researchers are working to identify different biomarkers in a patient that predict the patient's response to TMS, for example, EEG patterns, or perhaps there might be a genetic marker that indicate who would benefit most, which allows for personalized treatment plans and also increasing effectiveness. Again, I think this is one of the hallmarks that I'd like to have for our slide for today, our presentation for today, is reaching out to the community and bringing people into the treatment and indicating how it might be a wonderful, I think, frontline treatment in a lot of cases, or at the very least, alternative or adjunct treatment. But the collaboration between mental health professionals is crucial. We do believe in holistic patient assessment. That's the collaboration between the prescriber and therapist. The prescribers who generally administer the TMS oftentimes work closely, especially at our clinic and others, with therapists or counselors to understand the mental health history, symptoms, treatment goals, and by having this collaboration helps identifying the right candidates for TMS and tailoring to their individual needs. Also, having the counselors or therapists around provide insights to changes in behavioral patterns, coping mechanisms, response to traditional therapies, that this helps with, they oftentimes complement the ongoing psychotherapeutic interventions, having the therapist report back on what changes are occurring during TMS treatment. With treatment planning, mental health professionals can work together to integrate TMS with the other therapies that are ongoing. This oftentimes helps reduce symptoms to a level where patients maybe can engage more effectively in therapy as they're having success, hopefully, with the TMS. As Dr. Friedman had mentioned, the medication management piece, that prescribers are managing medications actively alongside TMS, and then collaboration with these folks ensures that changes in medication regimens are coordinated with the TMS treatments. This can decrease potential interactions, can increase the safety profile, and optimize patient care. We want the same brain in the chair every single treatment session, and if they have a medication that they go off or on, can change the nature of the brain during that particular day. And so to make sure they're getting the right dosage of magnetic energy to the brain, or decreasing the odds that they might have some sort of seizure reaction, critical to have this kind of communication. Also, monitoring or adjusting treatment. Regular communication between the providers is essential for monitoring progress. Again, therapists can provide feedback and changes in mood, behavior, cognitive functioning, and this can inform some adjustments to the TMS protocols. And so it's interesting how TMS starts to work in the brain. It's a very complex organ, and some people might start going to the gym more often, might clean their house, they might have a different type of dialogue. And so being able to see how the neuroplasticity and some of these changes emerge in a psychotherapeutic context can be powerful and inform the treatment. Finally, patient education and support. Mental health professionals can work together to educate generally about TMS, the benefits, the risks, and what to expect during treatment. This helps set realistic expectations. Again, TMS is not a silver bullet. It's not everything, but for a lot of folks, it's an important something. But it's also a lot of time. It's a lot of commitment. It's 36 sessions over the course of 7 weeks on a daily basis. And so helping people understand that type of commitment, if they're going to give a lot of energy into this protocol or to this treatment, having a realistic expectation is critical. This also helps treatment adherence as well, to have this kind of feedback. Finally, on this note, emotional and psychological support throughout the TMS process. Having communication provides crucial emotional support from the therapists or supporting counselors, helps cope with anxiety about the treatment. It's novel for many folks. Many folks have maybe just heard about it in the news. Also helps with concerns related to symptoms or just general concerns related to the treatment. In conclusion, the successful use of TMS in mental health care depends heavily on this type of collaboration. Turning it back to Dr. Friedman, he'll share more information about identifying who could potentially benefit from TMS and what steps to take next.
All right. And I do love that collaboration. It's crucial. #1 in my book, for sure. It's a beautiful thing. So identifying eligible clients. There's different requirements from varying insurers. We have a whole checklist of which insurers are proving what and what are the requirements. But in general, for adults, diagnosis of major depressive disorder is needed. Many require that the episode be severe. We do each one, for everybody that comes in, we do a consultation first to fully assess, make sure that there's no contraindications, make sure that this looks like it's going to be a good treatment for somebody. Failed to receive satisfactory improvement from medication. Most insurers require 2 unsuccessful medication trials. Some don't require that, but most do. Some insurers require a failed psychotherapy trial as well. And again, we have to keep looking, make sure that we're in line with whatever insurance that we're dealing with. OCD is FDA approved for treatment, and it's not just for NeuroStar. It is for other machines that are out there as well. But many insurers will not cover it yet. But that doesn't mean we can't treat for it. We can treat for it. If we're treating somebody for major depressive disorder, we can still treat for the OCD as well. So exciting things coming up there with the research that's coming out. And in general for adolescents, and now this is new and exciting for us as well. So the FDA has approved just newly for NeuroStar for ages 15 through 21, first line now, as an adjunct with medication, a medication regimen, or psychotherapy. So that's different from the adults, which is really, that's awesome. Insurers may require unsuccessful medication treatment or psychotherapy. Those kinds of things are still coming out as insurers are getting on board with the newly FDA approval for adolescents for the NeuroStar machine. And next slide, please. And it might be frozen on my side.
Oh, I've got call to action on my end.
Oh,
Dr.
there it is.
There you go.
It must have just been slow on my side. Thank you so much. Appreciate it. So call to action, just what we can all do to help. Help to educate and demystify what TMS is. Know which practices are providing TMS. I know Dr. Jewell had mentioned some that are out in the community doing great work out there as well. I love it that we're a community and we're trying to help people get better. Reach out to TMS practices with any questions. We for sure will take any questions that anybody has. We're always happy to talk stories and or do outreach, as I'm sure the other clinic practices are as well. I don't mean to speak for them, but they're great folks out there doing this work. And let's just all together help folks that have not found relief from traditional treatment protocols. I love that there's more options available when traditional protocols have not worked for everybody. I love this. TMS is non-invasive, is covered by most insurance, and may help when other treatment modalities have failed. And I think I have just one more slide up there before we get to the questions. You guys are all mental health warriors. And thank you so much for all that you folks do. We really appreciate it. You know what? Being in this meeting too, it really just underscore that we're all in it together. Let's just help everyone be healthy and well, including ourselves. And thanks so much. I appreciate everybody's time.
Thank you so much, Doctors Jewell and Friedman. Really appreciate this incredibly informative presentation. I learned a lot about TMS, and I'm curious about some things more on the insurance side and things like that. But before I ask questions, does anyone have from the council or as guests questions?
I guess I have two questions quickly. The second one might be similar to what you have in mind, Dr. Almer. My first question is, it seems to me that there could be a really valuable role for TMS in addiction treatments, especially seeing its efficacy historically with smoking cessation and with OCD, and its ability to target certain specific brain areas, such as the prefrontal cortex. But I'm not aware of any stuff coming down the pike with a treatment focused on addiction. So I wanted to ask, the first question is, do you know of anything like that?
At this point in time, I've come across articles and just becoming generally educated about TMS. There's larger organizations that have membership that are really pushing research in different directions, and addiction certainly has come up. I think that's where you can have a blend of high frequency and low frequency treatments, where mood regulation and managing the dorsolateral prefrontal cortex on the left side, that innervates with a lot of different areas of the brain. and then having a lower frequency inhibitory effect on maybe some of the impulses or some anxious states that might arise during the path of development or experience of addictive cycles. And so I can't speak with, I don't have a specific research that I can cite to you, but I'll look it up and I'll send it your way.
Awesome. Yeah. My next question is a little bit more maverick, but I noticed repeatedly that I'm a psychotherapist and I'm a talk therapist. I don't prescribe medication, although it's fairly easy to call a colleague if I want someone to trial a medication with a client that has depression, for example, or anxiety. But when I noticed the frequent sort of buzz line coming from the insurance companies, like, that there should be at least like 2 failed trials with medication before TMS is initiated. I'm wondering if that is primarily, is that because of a clinical reason, or is that primarily because it's just protecting the pockets of the pharmaceutical industry? Because this seems like it might have a high level of efficacy without medication treatment. I'm just sort of nonplussed, like, why do they require 2 failed medication trials? I have many clients that might be good candidates for medication, but for whatever personal reasons or spiritual reasons or health reasons, they don't want to take it. And I think it would be really great if I could just provide them with an opportunity to get at least a trial with TMS treatment. So I'm wondering if either you or Brendan could speak to that. Thanks for taking my question.
Sure. And I'll dodge the larger political whale that's been thrown on the conversation, but what I will say is that there's advocacy that I know more intimately with Neurostar, the company that we work with, that they've really pushed. It used to be 4 or 5 treatment medication failures from multiple classes, and that's shrunk down to 2 for most insurance carriers in Hawaii, and TRICARE has a failure of 1 for our military members. So things are changing, and there's advocacy, and I think that it's not happening overnight, but just in the course of our providing treatment and in the last couple of years, this advocacy has been effective. I think the numbers speak for themselves, and there's a lot of people that do want a frontline treatment that's non-systemic and not going to provide some of the challenging states that occur with medication failures and medication successes too. There's a lot of symptoms that come even when your antidepressant is working well for you mood regulation wise. Dr. Friedman, did you want to add anything to that?
I just wanted to say I love where you're coming from. Thank you so much for that question. We feel passionate about that also. They did it for the children, the adolescents, and I truly do believe that it should be a frontline, first line treatment for folks where it's not appropriate, or they, for whatever reason, they don't want to try medication. And I'll tell you, just from my own experience, I'd much rather somebody trial this first than medication. That's just my own personal bent on it. So I love the question that you just asked. And I love having more treatment options out there than just throwing meds. None of us want to do that. There are side effects always. And that was one of the big points that I did not have time to put on that slide. And I know we all know this, but the systemic side effects that you get from medications, I mean, they're for real, and there's always risk. There's risk in this as well, but I'd love for this to be available as a first line. So thank you so much for that great point that you brought up. I really appreciate it.
Thank you, Dr. Jewell and Dr. Friedman and Dr. Reese too. That was a very similar question I had, because I know for FDA, for children and antidepressants, there's a concern there. So I was really confused why it was one way or another for that, but not for adults. So thanks. I appreciate that clarification. We're running low on time, but I want to make sure both Second Vice Chairperson John and Leah both have their questions. So I'll head it to you, John, first, and then Leah.
Okay, I'll be brief. I was just curious if they've seen any of Dr. Zhao's work, and they've worked with people with brain injuries, like head injuries and traumatic brain instances or strokes.
With our clinic personally, we've been mostly focused on mood regulation and treating depression and anxious states, PTSD. We're still, as we join national organizations, yourself on the different applications. absolutely, we'd want to treat, we want to use this treatment to treat more folks. I'm not familiar specifically with that research, but it's an important area, a place to help folks that I think TMS can be really helpful in. Dr. Friedman?
Well, I agree with you. In fact, it's a really good question that you brought up. I really appreciate that. When we're doing the consultation, that's actually one of the things we look at to see if there was traumatic brain injury, and how long ago that was. If somebody, and currently, just because we don't have that research down pat yet, if somebody had recent traumatic brain injury, we probably, well, I'm not going to say probably, I would go against trying TMS right at the moment. That's not to say in the future, if there's more research that comes out, and there is plenty of stuff and interest in this right now, that we can get specific and localized with that where it can be helpful. But we definitely, we're still kind of new in the game in understanding TMS and whatnot. We certainly don't want to hurt anybody more than they are, for sure. But it was a wonderful question. And I hope that no matter the treatment, we can get better at that, for sure.
And maybe a bit of a plug for Dr. Jason Kiefer and Brain Health Hawaii, that's something that they really specialize in the brain mapping and doing some of the treatment for that particular condition. So that might be a good next place to reference. And also the TMS Clinical Society, there's a lot of research that goes on within that organization specifically devoted to this.
So thank you so much. And then I'm going to hand it to Leah here for the last question. Yes.
Thank you. So I head up the Division of Vocational Rehabilitation, DVR, with the state, where we help people with disabilities with training and employment and things like that. And the majority of the people we work with have mental health concerns, a lot of them depression and anxiety. And so my question is, I know you mentioned that there's a significant time commitment, condensed time commitment, or maybe extended condensed. Do you have experience with any of your patients who are in training or are working and are able to continue that, or does it vary? Does it knock people out so that they cannot? Or
Dr. BSI nodding.
Dr. Jewel and I are looking at each other. It's such a wonderful question, wonderful, and really important. So that's a beauty of TMS too. It's not like ECT where it's, it's really high intensity. Folks are able to continue on and work. It is a time commitment though. They have to come to the office 5 days a week for the full 6 weeks. And then we taper down for a week or two after that. But other than that, they're okay. They can drive to the appointment. They can drive back home, and most of our folks are working parents, and they're able to continue on with their day without real high intensity side effects, which is a wonderful thing. So it's just getting to the office. So finding a location that's convenient, we'll definitely work with in our clinic, and I'm sure the other clinics too will work with folks on their schedule. Folks' schedule changes all the time, and we will work to place them at a time that works for them in their busy schedule, because we know it's such a big time commitment. We do have some exciting options for folks that are tolerating treatment well. We have a condensed version, which is called Theta Burst, which is researched and FDA approved as well. That will have it condenses everything into about 3 minutes. And it's not for everybody, but for folks that are tolerating it well, we can do the treatment in 3 minutes versus 18 and a half that it generally takes. So there are options. But again, I love to babble, so I'll cut it there. But it was a wonderful question that you asked. Thank you so much. And thanks all for all that you do too out there.
thank you. Thank you so much.
Thank you, Leah. And thank you, Dr. Jewel and Dr. Friedman, for your wonderful presentation again, all your answers to the questions. If anyone is interested, I'd hope you'd be able to share your email. I think I saw that on one of your slides, and maybe if you can share your slides, that'd be great too. It's incredible information. So thank you so much. We'd love to see you again at these meetings. So please feel free to join us once a month here on Tuesday. Really would love to have you. Thank you so much. And then I'd like to end this portion of the new business and go into our our reports. We only have 3 minutes. I try to be mindful of everyone's time because I know everyone's very busy and I know everyone has quite a bit going on. So I realize that some of you have to go, totally understandable. Leah has already sent in her report. We'll rest on that. But what I want to do is just open it up and ask if there is anyone who has an immediate report they would like to present now. Before I go down the list, because I know Kathleen's not here, Ray's not here, and Leah has her report that's already sent in. Yeah. John, did you want to give a quick report? I know you have to leave. Yeah.
Sorry, my buttons are not working. Yeah, I'll just give a quick report. So the Medicaid program are looking at, I know we talked earlier in the meeting about Hawaii State Hospital and discharges from that facility, so, and overcapacity and whatnot. So we're looking at some of you may be familiar with our CCS program, Community Care Services, SMI, SPMI population with can't remember what the other thing is, but anyway, that population we treat through our CCS health plan. And so we're looking at collaborating with AMHD and looking at how do we, when folks get discharged from that facility, they automatically go into the CCS program. Before it was like, hey, you have to qualify, and then we lose track of folks lose track of them after they get discharged, and then things go squirrely after that. So we're looking at sort of like putting them into the program as soon as they discharge for the Medicaid eligible folks. But that's sort of like we're designing the process and thinking the flow and how it's going to work and collaborating with AMHD on some of those things. So that's something that's so new that we're kind of like leaning into over the next quarter or so.
Okay, that sounds good. It sounds like a puka that needs to be, addressed. So thank you so much. Thank you, John. And then Christine, I noticed you had your hand up. Want to make sure, offer you opportunity to report.
I just emailed your report also, Christina. Thank you.
Oh, for some reason I can't hear Christine. I'm sorry. I know you're saying things, but I can't.
Thank you.
Okay.
Just in respect for time, I did send that out so that people can read that, but just 2 new initiatives that's happening as the school year starts. One, our priority is around attendance. We have a campaign that will be starting in September, Attend Today, Achieve Tomorrow, for regular attendance. And then the second new initiative regarding mental health is free parent coaching and mental health topic growth series for our families. And we're doing that with parentguidance.org. And that's free to all of our families as well as to staff if they have children and want to use that.
Awesome. Awesome. That's great. Thank you for the reports. I really appreciate that. It's very informative. Thank you so much. All right. And I'm glad Panorama is getting utilized. That's good. It'd be great to hear some data or learn about the data that's collected later on. Okay. I want to be mindful and respectful of everyone's time and their plans today. Any other urgent reports? Otherwise, one can also email report to. I'll try to make it so that we do keep more time at the end because these reports are important. It is important to hear from all of you. So I apologize for the tight schedule today. Okay, since I hear nothing or see anyone eagerly, I will thank everyone for your time, the incredible engagement, all the information today. It's been incredibly informative. Any announcements before we close? All right, hearing none, seeing none, thank you all so much. I'm going to adjourn today's meeting at 12:01 p.m. Apologize for going over. Thank you. Have a wonderful rest of your week and month. I'll see you next month. Bye-bye.
Mahalo, everyone.
Mahalo.
Take care. Bye-bye.
You.
Thank you, Dr. Amr.
Oh, Carolyn, are you feeling okay? I was gonna tell you to go home.
I'm
you
going to go
know?
home. It's really not working. I'm going home.
I was just gonna say, just go home, rest.
It
like
was
you
very
need
special
sleep.
though this today. Yeah.